So good evening, doctors. I'm Dr. Namra Sheikh, Associated and Medical Advisor with Emcure Pharmaceuticals. A very warm welcome to all of you on this digital platform for another exciting session on No Thrombosis Workshop Series in Acute Ischemic Stroke. It gives me immense pleasure to introduce our course director for today's session, who is none other than Dr. N.R. Inchaporia. Sir has set up the first neuro ICU and neuro intensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India and has the credit of delivering more than 300 public lectures and workshops on stroke. He is a member of ISA Strokeicon, founder of the Pune Stroke Group, and ex-president of the Society of Neurosciences Pune and Maharashtra Academy of Neurology. He has been part of multiple multinational stroke trials as the principal investigator for Perform, Brain, and Interact, to name a few. He has been awarded as the health icon by the Times of India Group. We welcome you, sir. Thank you for being on board today.
Thank you.
Moving ahead, I would like to introduce our moderator for today's session, who is Dr. Anshu Rohatgi. Sir is working as consultant neurologist and professor of neurology at Sir Gangaram Hospital, New Delhi. He is the secretary of the Delhi Neurological Association and the joint secretary of Association of Neurologists in Clinical Research, Mumbai, the coordinator at the NABH, and principal investigator for more than 24 studies. He has the credit of 47 publications in various national and international journals and has presented more than 25 scientific papers at various conferences. A second moderator for today's session is Dr. S.P. Gothi. Sir is working as a professor in the HOD in the Department of Neurology at Bharti Hospital and Research Center. Sir has got the credit of receiving the National Merit Scholarship in 1976 and the Best Research Paper Award in Neurological Manifestations of Acute Immunodeficiency Syndrome. He has received the 8th International prestigious Sardar Patel Award for Excellence in Neurosciences Research, a Lifetime Achievement Award. He is the life member of API, IACM, IAN, and has been the organizing secretary and faculty for multiple workshops on stroke. He has the credit of more than 30 publications and more than 30 textbook chapters on stroke, and has been principal investigator for multiple multinational stroke trials like the INVEST trial, Instruct, Sprint, and Enchanted, to name a few. We welcome you, sir, today.
Thank you.
I would now like to welcome Dr. Abir Goel, who is the speaker for today's session. He is working as consultant neurologist at Paras Hospital, Panchkula. He has the credit of multiple national publications in national and international journals and poster presentations in national as well as international conferences. We welcome you, sir. A second speaker for today's session is Dr. Shishir Pandey. Sir is working as consultant neurologist at Indraprastha Apollo Hospital, Delhi, and has the credit of publication in various national and international journals and poster publications in national and international conferences. We welcome you, sir.
Thank you.
Without further ado, I would now request Dr. Inchaporia, sir, to continue the session.
Yeah, thank you. And welcome to everyone. Dr. Gorti, Dr. Pandey, Dr. Goel. This no thrombosis has been, the monthly meetings have been going on for about 16 months, I think 16, 17 months. And they've been a tremendous success, I must say. And every month we present few cases, and there is extensive discussion, often late into the night. I, for one, have learned a lot from these discussions, and some of the most fantastic cases have been discussed. And I'm sure today we will also have a wonderful discussion along with Dr. Gorti. And I would like Dr. Gorti to say a few words, and then Dr. Abir can take the first case.
Thank you, sir. And it's indeed a pleasure to participate in this forum for the first time. I believe you said that it's been happening since a lot of time, but I got the opportunity now. And thank you very much, Emcure, for giving me this opportunity. So we'll get going today's case presentations. And I think Dr. Goel is going to present the first case. And we'll have this present. Yeah, Goel is going to. Okay, Abir, I think you can start your case, and we'll have a discussion at the end of the case.
Okay, so Dr. Namra, shall I share my case?
Yes, share your screen.
So I hope everybody can see the screen.
Yes, fine.
So very good evening to one and all. First of all, I would like to say thanks to all my teachers here and the opportunity to learn about stroke and the further management through this platform. It's quite surprising that it's been 19 or 18 months and 16 months, and I am, I'm very unfortunate to probably join it now. I think we must have learned a lot of things through this platform. So I just hope to bring something new on the table today through this case. So I shall be presenting, in fact, two cases which are related to each other, which shall, I think, bring up more questions than answers, I hope. So presenting the first case is Mr. AL. He's a businessman by occupation. He is 47-year-old with no prior comorbidities, and he had presented to our emergency with an acute onset illness of left upper limb and lower limb, with facial deviation to the right side since 1.5 hours. Now, going through the timeline, so at 0 minutes, he walks into our emergency, he is brought into our emergency. And at that time, the only two things what is recommended before any stroke cases, BP and the sugars. So his blood pressure was 144 by 88 millimeter of mercury, with random blood sugar at that time was 98 milligram per deciliter. So immediately, so in our institute, we have a very good stroke unit. So immediately the stroke unit was informed. In fact, when the patient was on the way, then only we were informed. So we were pretty ready for the patient. And patient was immediately shifted for CT scan. So unlike the others, our plan here is the moment patient comes to the emergency from outside only, we check the BP and RBS, and on the same stretcher, we shift the patient to CT. Hence decreasing our or improving our door to CT time, door to imaging time to 10 minutes. And this is the imaging what we can see here. So what we figured out in the imaging was, we can see that there was an insular ribbon sign suggestive of an acute stroke. And here what we can see is a hyperdense vessel sign. So we can see the inferior division of the MCA, of the right MCA is hyperdense, thus suggestive of probable thrombus in the MCA. So based on that, immediately the patient was shifted back to emergency for assessment, detailed assessment, and counseling of the attendants. So the things what are done before the assessment and counseling attendants, we do it after the CT, so that the CT is also processed by the time we are done with the assessment and counseling. So in the assessment, the patient was conscious, oriented, and alert, responsive with a normal gaze, language being normal, speech being normal, with facial partial paresis on the left-hand side, with no heminopia and left-hand side hemiparesis of power of upper limb of 3/5 and lower limb of 4/5, with sensory and cerebellar findings being normal. And the repeat BP when the patient was brought back was 138/84. Hence calculating the NIHS score of 5/42. So immediately within the next 20 minutes, we did the analysis, we did the we counseled the family members about the need for the thrombolysis. Blood sample for investigations were drawn, Foley's was inserted, and thrombolysis was started. Thus, the total door to needle time was as low as 30 minutes. We had given him a directive place at 0.25 mg per kg, so it was around 18 mg given stat, with BP at the onset of lysis was 140/80 millimeter of mercury. So immediately after the lysis, we actually shift the patient for MRA here this time. thus confirming that what we can see here is the diffusion. We can see a restriction at the temporoparietal area, and here also we can see the same restriction being present here. But in the flare, what we see here is a partial diffusion flare mismatch. Now, this we have heard about a term called diffusion flare mismatch and diffusion flare partial mismatch. So what does that mean is that if the flare is hyper intense, if the diffusion is hyper intense, only a part of it, what we can see here in this second image, only a part of it is hyper intense on the flare. So this is a partial flare mismatch. The classical diffusion flare mismatch is hyperintensive diffusion and absolutely normal on flare. So we call it a diffusion flare partial mismatch. And again, the thrombus was confirmed on the SWI imaging. So yes, a week later, we did the thrombolysis. The patient improves to a near complete status. As we can see, the power of the right upper limb has improved. His power in the right lower limb, the left upper limb and the left lower limb has also improved. Thus, the patient has a near normal recovery within a week. So what did we learn from this? It was a clear-cut, simple case. Patient comes within a normal time, within a normal thrombolysis golden period time. We thrombolize the patient improves. But extending the same learnings through another case in which Mr. OP, a school teacher by occupation, 45-year-old, hypertensive on irregular medication, had presented to us with an acute onset weakness of this time right upper limb and lower limb, but not been able to speak or understand, with the unknown time of onset. Now, what happened with this patient was, since he was aphasic and he was last seen normal 5 hours back before the break time and this thing, and after that he was found in a stuporous or in a confused state in his school bathroom. So he could not really tell when was the onset. So we had an unknown time of onset, and this patient was shifted from Ambala, which is 1 hour from our hospital. So last seen normal was 5 hours back. So again, at 0th minute, the patient presented emergency with stroke of unknown onset of time with a BP of 160/100. RBS of 82, shifted this time for an MRI scan since we didn't have the time of onset. So door to MRI time this time, since the patient, we already knew the patient is coming. So we again shifted the patient immediately on MRI for 5 minutes and again shifted back to emergency for assessment and counseling of attendance. So what we can see here in the MRI is that there is a definite diffusion restriction in the inferior temporal area. And what we can see here, again, there is a partial mismatch. So we can see there's a wedge-shaped infarct here, wedge-shaped diffusion restriction. But in the flare, there is just a hyperintensity on the periphery. In fact, the gyral hyperintensity is there, not really involving the whole of wedge, which we can see in diffusion. Thus, again, giving us a image of a diffusion flare partial mismatch. So what is the answer? And if we can see from SWI, we can see an hyperdense blooming seen in the inferior division of the MCA, which we can see here. So it thus confirming us the diagnosis of a stroke. Now, on the assessment, the patient was conscious, not really responding to command, with partial gaze deviation to the left, with global aphasia and speech dysarthria present. Partial facial paresis was present with no heminopia, and left-sided hemiparesis. Sorry, the right side hemiparesis, right side hemiparesis of upper limb nearly hemiplegia, monoplegia, and lower limb 1/5. With sensory, yes, a withdrawal to noxious stimulus was seen with cerebellar normal, and repeat BP was 164/90. So NIHS total amounting to 19/42. So within a 45 minutes, next 45 minutes, family members are counseled. The MRI was analyzed, the blood sample for investigations were drawn, Foley's and RT were inserted. And this time, the door to needle time was 45 minutes. Again, tentative was given, 15 mg stat, and BP at the onset of lysis was 168/94. Repeat CT, as we can see, within 24 hours, didn't show any evidence of hemorrhage, did show a wedge-shaped infarct. With physiotherapy was immediately started, with antiplatelet statins was started, and the patient was evaluated for young hypertension, stroke, and risk factors were controlled. So this is 3 months post-treatment. As we can see, patient had a considerable, almost a near normal recovery in the motor. The aphasic part, yes, the patient is still under the speech therapy in which the patient has been taught to learn about the different alphabets and all. So what is this diffusion flare partial mismatch? Now, if we go about the wake up trial by the Thomel and co-authors, the diffusion flare mismatch is only scored positive if the areas showing restricted diffusion had no flare, no finding on the flare. So does that actually include all the patients who are eligible for lysis? So for that, real world data was published in 2022, in which, yes, they did have only 4 patients who had a diffusion flare partial mismatch. And another report was studied by Jakubik, and in which they had studied 27 thrombolyzed patients with partial mismatch. And what did they find out was, yes, first of all, even if there is a partial mismatch, there is no increase in the hemorrhage rate. Also, the beneficial effects of altiplase was similar, even if there is a partial mismatch or a total mismatch. So the point here, what I would want to discuss with everyone here is, whenever we talk about a diffusion flare mismatch, are we just ruling out the cases because there is a partial mismatch, or are we including those cases also when it comes to thrombolysis, especially in the times of unknown origin? So yes, what my conclusion would be, the mismatch pattern used in the wake-up stroke might be over-selective, and this is definitely thrown to a discussion that what is the experience of others. Thank you.
Thank you, Dr. Goel. And sir, can I make comments? And Dr. Chapuria? Okay. Dr. Alok, it's like this. There is a known fact that there is a SN ratio, the signal to noise ratio. If it is 1.3 or less, we still go ahead with thrombolysis in cases of diffusion flare mismatch, which we usually take as less than 6 hours. So it's a sign. It's not a sign one on that if you see on flare that we should not thrombolyze. But that differentiation we should be able to make, whether it is 1:1.3, the difference, and if you are partial mismatch, what you're referring is a thing that we should, and moreover, both the cases are large vessel occlusions. And so of course, NIHS was one is 5 and the other one is of 45. I mean, it's about, I think, 12 or something like that. 19. So it's a big NIHS, but you went ahead and did. And actually, we are slightly, the patient comes with do NIHS and LVO assessment first. Whether large vessel occlusion, we use band scale immediately and see before while going on to the CT scan. So then we try and bridge. But the first case would have been very ideal candidate with the 10 actiplase injection, and if opportunity is there, we can do EVT. That would have been excellent case. The other gentleman, we don't know. That's so we would have resorted to CT perfusion or the MRI perfusion, because after the timeless trial, which is published in NEJM, now the extended time window is up to 24 hours. Yeah. So that's another very comforting feature for us with 10 actiplase, that the first trial that has happened beyond 9 hours, beyond, we still can use. So we have to perfect our technique of CT perfusion and MRI perfusion beyond diffusion flare mismatch. So I think we had to get up to that thing, and we're partially using ASL nowadays. So ASL also will give some idea of what is the penumbra in the stroke zone. And if there's a clinical radiological mismatch, definitely we should go ahead. And the first case suggested that there is a clinical radiological mismatch, but fortunately, I think wonderful drug. It has improved and has become all right. That's proof of pudding is that. But these are the learning points and discussion issues. Dr. Ichapuria?
Yep. Dr. Goel, 1 or 2 points. First of all, it's excellent. Your door to needle time and door to CT scan time are absolutely first class. So many congratulations for doing it that way and to have that stroke code in your hospital. It's very important to do what you're doing. And so many congratulations for that, because this will help many patients. However, I have 1 or 2 points to this thing. In your first case, why did you do MRI immediately?
So just to check about the fact that we were done with this thing, just to check upon the fact that how much the stroke is. That is for our, you can say, the academic purpose. Since we had already done the thrombolysis, we had done the MRI immediately for the two things, that how big is the infarct, and just for more of an academic purpose, that since we need to know.
Yeah, so actually it is not necessary to do
It is
that.
not necessary. It is not.
It is
It
not.
was more for an
So
academic
I would
purpose.
advise you that, if you, how much was the NIHSS in the first case you said?
Five.
It was 5. Okay. So, usually what our protocol is, in both these cases, you have not done a CT angio or MR angio.
We had done, I've just not shown that, because that's why I had shown this thing. In both the cases, we had done the CT.
Yeah, so I think you should show that, because you see, that's very important. We should always look for CT angio and see if it is an LVO. Now, very importantly, and I'm very strong believer in this, that many cases of LVO do respond to IV tenecteplase. I mean, people fight with me endlessly and very vehemently, but I have seen it umpteen times, more times than I can ever remember, that, LVOs in the MCA have opened up. And, in the first case, probably it was in M2. I mean, you haven't shown the CT angio, so I don't know, but at least M2 was involved. So M2, they really do open up, and they really do very well. So I find that doing the diffusion flare mismatch in the first case is totally unnecessary. And maybe you just did it for your purpose, but you're just spending money unnecessarily. And what are you trying to gain? You're not trying to gain anything. So it would be better if you had shown the CT angio and shown that this diffusion flare mismatch in the first 6 hours, or when the time of onset is known, or first 4.5 hours, is frivolous. It has no meaning. This should not be done. It is only to be done when it is a wake-up stroke, or it is an unknown onset, unknown time of onset. But, doing it when the patient has come within the window of 4.5 hours is of no use, because and I find that, many times this MRI confuses you, and it delays the treatment.
So what we do in our hospital, Dr. Goyal, is within 4.5 hours, we do CT angiography.
Exactly.
And after 4.5 hours, we do MRI brain diffusion and perfusion, if possible.
Yes. So I think every patient you should do CT angio. You'll be surprised.
We did have the CT angio in both the cases, and both the cases didn't show any LVO in ICA or M1 and M2. In both the cases, the block was actually in the inferior division of MCA, more towards the distal end also. So we had even consulted our neurointerventionists in both the cases. And both the cases were actually not...
because you hadn't mentioned it, that's why I'm mentioning it.
Yeah, sir. And that is why...
And you had shown in the Sylvain Fisher that dense MCA sign, which is, I think, M2, M3, it would be. So
it's not M1, it's beyond M1.
No, it's beyond M1. No, M1 we don't know. We haven't seen it.
It's not.
So, but definitely it's at M2, M3, and the IVT has worked excellently well for this patient.
Yes, and both have.
So because you had not shown it, we didn't know. So therefore I made this comment. So what I'm finding is many people are doing this diffusion flare mismatch and making a big issue of it when the patient is come in the window. It is not necessary in the window. It is only necessary when it is outside the window, or it is unknown time or wake up. And in those cases, in the second case, I couldn't really make out that there was any change in the flare. I mean, minor changes in the flare, I think we should pass as normal. I mean, you really have to strain very hard. I was straining very hard to see where that flare, this thing was. But to my naked eye and my brain, it appeared that the flare was normal. So I would have thrombolized this patient straight off. And Another
we
thing
can
I
send
would
this
suggest to
message,
you,
sir.
yeah,
Before we close of this case, we can send this message that within 4.5 hours, CT angiography is a must.
absolutely,
And after
absolutely.
4.5 hours and wake up stroke, we should go
Absolutely.
for
That is the
MRI and
message
MRI.
that, we should give to the public,
Yeah.
because, we are finding many people are doing MRI at 3 hours. It takes longer to do MRI
20
than
minutes,
CT
the stroke
scan. No
MRI, if
doubt
you
that it
want to
takes
do 20
longer.
minutes.
And it takes longer to prepare the patient for MRI.
CT took, then you have to shift to MRI. Then
Yeah. So I think this message is very important, that, in your casualty, you should put this board up. Ki, "Arey, he has come within 4.5 hours, do CT angio." Especially if NIHSS is more than 6. But even in NIHSS less than 6, it is worthwhile doing CT angio, because many times you do find LVO, and it gives you a more clear picture for prognosis and management.
Thank you, sir. Then if you permit, then
Second,
we'll
yeah.
want to say one more point. Yes, sir. Because they're already
What was that other point? Another thing I would urge you, that you are shifting the patient straight to the CT or MRI, but I would urge you, to give the thrombolytic agent in the CT scan and in the MRI gantry itself.
the gantry, it
That
should
will
be done.
save you another 5 minutes.
Yes, that's a
That will
wonderful
save
point.
you another 5 minutes.
We always
And
give in gantry.
assessment can be done as you are shifting the patient to the CT scan. Don't wait for the CT scan or the MRI, then shift back the patient to the emergency room, there do the NIHS, and there again you are wasting 5-7 minutes. So, time is of the essence.
I think we should make a package, a kit of thrombolytic therapy. Keep it ready when the patient is going to CT scan. It should be given in the gantry. That is the third.
It should be given in the gantry. So maybe, these are fine tuning, but I think you have done extremely well for both the cases, and we must congratulate you for that.
Full compliments to Dr.
Yeah. There is no doubt that. But maybe you may take it's not a criticism, but it is just a fine tuning to get better results.
Yes, we live and learn. There's nothing wrong. We live and learn. All of us keep.
No. So little fine tuning always helps everyone. It helps us also, and but nevertheless, in spite of all these things, I think you have done extremely well.
Excellent. I think
now many times, even the last few times, we look at the patient after 1 month or 3 months or whatever, and we say that his MRS has improved. But also, it's very important that we assess their cognition, because invariably there is cognitive decline. And we are not assessing that. We are just seeing limb power and sensory symptoms and aphasia and facial droop and limb weakness. But, formally, we must do a cognitive assessment. And this can help the patient. Many of them get depression. Many of them get anxiety. And, if you treat them, their quality of life improves dramatically. So
another important point that may have bearing on their employment also. So what they are going to do, employment, where they are going to be employed.
Of course. Cognition is very important for employment. It is very important for daily life also. They cannot understand the newspaper, or they were not as sharp. You talk to the family and they say, no, he's fine. He's walking, moving, everything. But, he's not the same.
Cognitive rehabilitation.
he's not the, I remember dramatically one patient, I was very happy that fellow improved completely. But then his wife told me, doc, he is not the same man that I married. He's a different man. So I was a little, I was taken aback, I said, oh God, we were so happy that he's walking, running, jumping. But his wife said, no, doc, he's different. He's not the same guy. And few months later, they had a divorce.
Oh.
So, it's very important. Another thing I remember, that one fellow, he was a banker with Citibank. And, I thought he improved superbly, but he just couldn't hold his job. He lost his job in 6 months. The bank said, "No, yeah, Mr. So and so, you're not working the way you do, and it's a multinational bank, and they're just interested in results." So I think I've been very guilty also, I must say, that I've not been assessing cognition.
Yes, sir. We
But
are not putting more stress on
I think
cognition.
we should put more
We
stress.
shouldn't, because so many neural
Cognition
networks are destroyed.
and mood and anxiety.
Yeah.
And these, so as a holistic, we are physicians treating patients, so to improve quality of life, I think we should look into these also.
Yes,
But
holistic approach.
overall, I think you have done an excellent job, Dr. Goel, and I wish you, and I'm really happy that you've got this stroke code in place and you're able to ship the patient so quickly. And this is what we want across the country. It's not happening. It's unfortunately not happening. And your door to needle times are excellent. 30 minutes and 40 minutes is superb. So many, many congratulations to you. And thank you for this wonderful presentation.
Thank you, sir.
Thank you, sir. Then if you allow, then we'll go to the second case by Dr. Pandey.
Anything more you want to say, Dr. Gorti?
No, sir. I think you have covered most of the points. Again, stress is a vascular cognitive impairment, which we should test at 1 month and 3 months.
Yeah.
And now presently I'm having 3 persons working on one PhD from language pathology student, and one of my neurology residents is taken up a vascular. One fellow has just completed vascular cognitive impairment. Very important aspect, behavioral problems, also post-stroke depressions, and we can intervene.
Yes,
that's the most important thing.
Dr. Goel, another thing you should do when you get such good results, you should advertise this in your local community. And it's not advertising. It's not advertising. It's giving information. And many small hospitals are not referring patients to us. They're keeping. See, this is a problem. I'm facing this big problem, They're sending the patient late. They're doing MRI far away, sending the patient after 6 hours and 5 hours and 10 hours, So, this work which you have done, which is excellent, you should go back into the community and talk to those people, or even give it in the newspaper, because these things are life-changing. And I'm sure the patients will bless you for the rest of their life and rest of your life. So,
Dr. Goel, you keep calling all these patients and do a stroke awareness program.
Yeah.
In the month of October 29th is a World Stroke Day. So all these success stories, and make a public platform. Okay.
Thank you, sir.
Thank you, Dr. Goel. Thank you so much. Yeah.
Okay, Dr. Pandey, let's hear your cases and we'll have a wonderful discussion at the end of the case presentation. Please.
I will try, sir.
I think Anshul couldn't join, sir, so I think we'll continue.
Has he joined?
He hasn't joined. What happened, Dr. Pandey?
I think my slide is visible.
No, it's not visible. Dr. Namra Sheikh, can you help him?
Shares. Share.
Sir,
Yes.
will you please start sharing your screen? Do you find a green box which is present at the lower part in display?
Yes, this is a share button.
Yes, yes. Please click on that.
I'm clicking it. I think it's not sharing.
So when you see the screen, can you see the option of a mic and then start video?
Share screen.
Yes.
Option of what?
Or else another thing we can do is that you can send me the presentation on mail. I can share it on your behalf.
Okay. I will do it. And your mail ID?
It's NAMRA. The mail ID has appeared in the chat box, sir.
Okay. I have mailed you. Please check.
Okay. Fine, sir. So will you please check once in your sent box?
That is. I think it is.
I have refreshed, sir. It's not received yet, I guess. It's not received yet.
It's not received yet.
Yes.
Anchor, you mailed it directly. The mail ID is the namra.sheikh@emcure.com, no?
Yes.
I have mailed it.
Sir, if I may ask you, what do you see on your screen right now?
I will mail you again. Please check.
Okay. Yes, sir. Uh, Sir, it's not received yet. Uh, Sir, if I ask you, what do you see on your screen right now? When you take the arrow towards the Windows bar.
Windows, there is a share option.
Yes.
And the portion of the screen, video, slide, and background.
Okay, I received it, sir. I will display it in moments now.
Okay. That's
Yes. Yes, sir.
Good evening, everyone. Sorry for this delay. Now, I'm going to presenting my two interesting cases for today's evening. As there is a dictum is the medical science that God cannot be so cruel. The gist is that there could not be a two different diagnosis, or God doesn't going to give you two different disease for a same patient. Next. In the first case, there is a 53-year-old female. She presented with the complaints of a sudden onset breathlessness from the afternoon of the 13th December 2023. Patient was initially managed in a local hospital, and during the time of the investigation at that place, they have done a 2D echo, which revealed a left atrial mass, and they have labeled it as a perimyxoma. Patient was well all right at that time, but while admitted in that hospital, patient developed a sudden onset weakness of the right side of the body, followed by drowsiness, and then patient referred to the emergency of the Indraprastha Apollo Hospital for further management. We have done an MRI which revealed next these slides. And there is a diffusion restriction in diffusion and ADC images, but there was a no flare positivity in the corresponding flare images. Next. As there is a no flare positivity, in spite of not knowing the time of the onset of this right-sided weakness and this drowsiness, we give the patient injection tenecteplase by 0.25 milligram per kg body weight. It thrombolized the patient, and patient was stable after the thrombolysis, and patient has undergone this transthoracic echo. So we do here this transesophageal echocardiography, and there is a large left atrial mass, but the mass is cystic and it has a septa at various levels. Next. So it is quite suggestive of it could be a hydatid cyst or it could be a left atrial myxoma. Although we have done this serum ELISA for the cystic circus antibody, which was negative at that time. Investigations like CT scan of the chest and abdomen CT for similar cyst were negative at that time. Rest all investigations were negative, in spite that this D dimer is high, that is 639. Next, this is the negative report of echinococcus antibody. Next. And this is post thrombolysis MRI that was done after 10 days of the to see any further progression or to see any cystic-circle in the brain site of neocytic sarcosis. And then this there is a flare positivity appears. Next. So regarding if you are going to explain the symptoms from the initiation, the palpitation or restlessness that patient had in the beginning could be the anaphylactic reaction due to ruptured cyst at the initial time. And the left thalamic region, in fact, it had happened, could be due to the migration of cystic component as an embolus. We managed the patient with the antiplatelets and antihelminthic, and patient responded to the treatment well. And we advised her for a surgery of the for the removal of the mass. But patient was unfortunately lost to follow up, so we can't trace the patient. My next case is next a 34-year-old man who is a bodybuilder by profession, presenting to the emergency department with a complaint of transient left-sided hemiparesis just after lifting the heavy weight. He is a reputed bodybuilder who is doing a bench press with a more than 100 kg weight. Patient has a multiple episodes after that, and after some of the episodes are associated with the left upper limb shaking. Next. On examination, there is a no focal neurological deficit. We have done MRI that doesn't show any acute infarct. We have done this MR angio and this vessel wall imaging. Next. This MR vessel wall imaging revealed a focal stenosis at a right ICA. And the all other vessels are normal. Next. And this is an MR angio image which show a focal stenosis at a right ICA and supraclinoid part. Next. So we also do a DSA, cerebral DSA, which revealed a 90% critical stenosis of a right ICA, and but the other dicey things have happened. That is, a routine hematological investigations revealed a hemoglobin of 18.1 gram, and corresponding hematocrit was 56. Could it be a polycythemia? So we do a workup for a polycythemia, that is JAK-STAT2 pathway and erythropoietin level and other hypercoagulable state, but all turns out to be negative. Next. So we are facing a two problem. One is the focal narrowing at the right ICA, another is the hyperviscous blood. Next. Regarding, we have searched some literature, so we found that it could be a case of an idiopathic non-atherosclerotic carotid artery disease. Up to as far as the literature is concerned, there are 4 major causes of non-atherosclerotic carotid artery disease. There one is dissection, other is fibromuscular dysplasia, third could be Moyamoya disease, and last is the inflammatory large vessel vasculitis. But here large vessel vasculitis is very unlikely because it could be involves other part of the vessels also. Moyamoya disease, it could happen from the in the childhood state, and there is no corresponding collateral developed in the MRI. Fibromuscular dysplasia, patient doesn't have any fibromuscular dysplasia features like an aneurysm and other disease, and dissection is very unlikely as there is no flap in the MR angio images. So here the final diagnosis is could be a focal stenosis that is due to could be a heavy weight bearing at that part, and his high hemoglobin is explained as the patient is a smoker. Next. So we manage the patient with a dual antiplatelet and statins, and for this high hemoglobin, patient undergo phlebotomy. But unfortunately, patient was readmitted again within similar episodes, and at that time we have added anticoagulants along with dual antiplatelets. Now patient is stable. Next. So in the last, the things is like that. God is blissful. Yeah, he is not so cruel. Thank you.
Thank you, Dr. Pandey. You got presented excellent 2 cases and very well managed. The first case, I think you are expecting both echinococcus and cysticercus cellulosae, both are different worms. One is causing hydrated and the other one is cysticercus, but you didn't find any cysticercus, but you treated with hydrated, treatment, that is albendazole. But that's our first question. And see, the LMS usually gives us a problem. And whenever, doing echo is not a prerequisite before thrombolytic therapy. Definitely. If it happens, then we'll get caught in situations where there's a clot in LA, LV, whether we should thrombolyze or no thrombolyze.
Or not thrombolyze.
There is no guideline as such.
But we have thrombolize first, and after that we do all this.
So that's the question. That's wonderfully done. And second thing is, I see a stenosis case. And this is intracranial stenosis. And presently, ICMR study is going on for 1 year dual antiplatelet therapy. But thing is that, is there any dissection suspicion when you initially took this case? Because it is associated with weightlifting and things like that. But you didn't find any dissection. You found only intracranial stenosis.
Nothing.
Okay. Vichapriya, sir?
Yeah. Dr. Pandey, see, in the first case, and the echo was done before the patient came to you with stroke. Is that correct?
Yes, echo was done for the evaluation of the breathlessness at the previous hospital.
So, when you find a differential diagnosis of myxoma or something else, I would not thrombolyze this patient. Because if it is myxoma, how is the thrombolysis going to help?
But so literature are there. But we have searched the literature, sir. But literature are there. Patient has a
literature may be there. See, it was thrombolized, but it's not going to help. So, if you get a large vessel occlusion with a myxoma, the treatment would be to do mechanical thrombectomy.
Mechanical, definitely, sir.
Yeah. So the thrombolysis, I think, should not be done. If you think of myxoma or you think of bacterial endocarditis or and I think what could have clarified the picture better for you would have been an MRI of a cardiac MRI in this case.
Definitely.
Cardiac MRI is very good for tumors and endomyocardial fibrosis. So the investigation of choice would have been a MRI of the heart, and that would have clearly shown you whether it's cystic or whether there was a scolex or whether there was a daughter cyst or whether it was a myxoma. And the medical treatment is not going to help. This is a case for cardiac surgery. Even if it is,
we have advised her, but patient lost the name of the cardiac surgery itself creating a havoc.
No, I'm just saying she went away. That's a different matter. But the treatment would be to do cardiac surgery in her case.
It's the removal
because it's not going to help. I mean, giving albendazole and all is not going to help in this case. This cyst is too big. It's not that albendazole is not going to penetrate inside and not going to kill anything. And if for all purposes, it may not be a cyst because cyst is so rare. I mean,
cardiac hydrated is very rare.
Very, very, very rare. And nothing else anywhere else in the body. I would really put my money on myxoma, and she would be a case for cardiac surgery because, it could just plop in and out of the mitral valve and occlude it completely and she could die immediately, So this is a case for emergency cardiac surgery and certainly not a case for thrombolysis. Now, the second case, I think you have covered it very well. Was he taking any supplements, protein supplements? Usually they do.
Maybe he is on a supplement. He is a professional bodybuilder.
Yeah, exactly. So all of them take something, and all of them take even some steroid, anabolic steroid,
Definitely, sir. Definitely.
and what is that other substance they take?
But the clinch is that what is the cause of that focal stenosis in the supraclinoid part?
Yeah,
So,
no, so that's what I was thinking.
that's
If what about this cholesterol and things like that?
everything is normal. So I have interviewed it detailed when he comes to the OPD. So he said ki when we do some squats thing by putting weight in his shoulder, after that I have got this.
Yeah,
So would it be
dissection is really high on the cards, huh? Though we are not able to show it on the MRI, but
CT
I would
angio may help.
really put my money, when you first said it now, I would put my money on intracranial dissection.
dissection?
CT angio
And,
will help, I think.
Huh?
CT angio will help, sir.
Yeah. So no, but he's done a
MRI.
vessel wall imaging. You did vessel wall imaging.
Definitely, sir.
See, it's not 100% that it will show dissection.
Definitely.
It's not 100%. But looking at that bodybuilding and putting that barbell on his shoulder and straining and high hemoglobin and maybe taking some steroidal drugs or whatever, I don't know what that does to the elastin of the vessel. It looks like a case of dissection.
DSA may help.
And then it has settled down with antiplatelet and additional anticoagulant. I think you have done well for him.
We have to add anticoagulant. Okay, again he have.
Yeah, that's okay. Yeah. That's okay. See, because he did not respond too well to only antiplatelet. So adding anticoagulation is not a bad idea. And it did seem to help. Now, whether it was due to that or not, now that nobody in the world can answer that question.
Definitely.
But it did help him. So I think what you should tell him is, first of all, stop taking all those anabolic drugs and get your hemoglobin down, and don't do this crazy weightlifting. I tell you, these gym injuries are so common, so common. And they are dissecting blood vessels, they are producing, and these gym instructors make them do so much. We've seen so many gym injuries, strokes, hemorrhages, because suddenly the BP, you're doing that Valsalva maneuver and the BP is going up and an aneurysm ruptures or there is an intraparenchymal hemorrhage. Umpteen cases of this type we have seen. So, this stupidity of doing bodybuilding and building muscles, and I think this is a lifestyle disease.
Overdue lifestyle disease, sir.
Huh?
Overdue lifestyle.
Yeah. Overdue lifestyle disease. You want to become sexier to the opposite sex, or God knows what. but it really produces harm.
We are encountering more cervical and vertebral artery dissections. Yesterday, we presented 22 cases in the Neurology Society of Pune, where we have encountered dissections in abnormal situations. And
in
most
what
of them are
situation?
like weightlifting and this thing and
weightlifting.
And even
this weightlifting is notorious.
Neck maneuvers.
Correct.
So any pain with stroke, we should suspect dissection.
Correct.
Pain and stroke.
Did he have pain? That is what I was going to ask you. Dr. Pandey, did he have pain, headache?
Actually, he had an headache at the time of the event. He is telling, but it could be he is telling I was dehydrated at that time. I cannot. I doesn't doing anything. I am not taking. Actually, he is on a weight cutting. He is preparing for the competition. At that time, he has left salt and he has left drinking water. And at that time,
he had headache. If headache is there, you should think.
Dehydration. See, because of dehydration, also polycythemia will increase.
Polycythemia could occur. So could be it like that.
Yeah.
So that time he had.
There is no sinus thrombosis. No, there is no.
So this is a pure lifestyle disease. Yeah, lifestyle. He has to improve his lifestyle. Forget about taking part. Otherwise, he won't have brain only. He'll get an infarcted brain. No use to him or anyone else.
Take home messages are two. The first case. And it's an excellent case, but it's very difficult to manage. And one thing we should do is that such cases, as Dr. Ichapuria said, it should have been subjected to surgery than treatment, no thrombolysis for it. Right? Second case, of course, intracranial, any case with the pain and stroke, dissection should come into first, along with venous infarcts are there, of course, they are there. But if such a situation, and with occupation, with sports, stroke, with pain, we should think of dissections.
Definitely, sir.
Yeah.
I think, sir,
Yeah.
shall we, if there are any questions from the audience, anything you want to ask?
No, we've had excellent cases. Huh?
Yes.
These that echo of that fellow was amazing. Yeah, I've never seen an echo of that type.
Never seen a hackett
So that's what I'm saying. Every time you see something new and unique,
Yes, yes.
Yeah.
Interesting.
Okay, so thank you, Dr. Pandey. Well done, and we learned quite a lot today.
Yeah, both the youngsters have presented excellent cases.
Yeah.
A lot of compliments to both of you, and you have done exceedingly well and wonderful cases.
Thank you, sir.
Shall we call it a day?
Yeah, Dr. Namra will take it ahead.
Yeah, Namra, please go ahead.
Okay, absolutely. Thank you for the very wonderful case discussions, Dr. Shirish Pandey sir and Dr. Abir Goel sir. Thank you, Dr. Richaporia sir, for providing time for this meeting, and it was wonderful to have you on board. Thank you, Dr. Gorthi sir. Your insights have been absolutely valuable, and today we have 420 plus attendees.
Excellent.
How many?
420.
So it has exceeded.
Okay. So good, 420 people have benefited in the world.
Yes.
Okay, that's good to hear.
Excellent. And very wonderful. Yeah. We look forward to more participation in future.
Okay.
Right, sir.
Good night.
Good night.
Good night.
Good night,
Thank you,
everybody.
everyone. Thank you
so much.